women at all phases of their life can have various presentations of pelvic floor dysfunction. You can't just say to that woman, relax your pelvic floor.
Just relax.
What is the pelvic floor? What the heck I do?
Hey, Lynn.
Hi.
Long time no see.
Not really.
Not really, though.
Why?
Oh, we had a nice workout this morning together. Yeah.
You look comfortable.
Oh.
You're good.
Okay. We did a little start to our morning in the gym, the basement gym.
Yep, as we often do.
Hi.
Moose, go lay down, please. Moosey, too much. Go lay down.
Honorary reverence member.
That's right. He's in so many yoga videos and things that the people have seen him.
They know.
They know.
That's what they're here for.
Really? Probably. It's true.
Yeah.
So yes, as we often do, we had a nice workout together. Always so much easier with a partner.
And it brought us to talking about our topic for today.
That's right.
Because we have the Prolapse Prevention Pact in our lifting, part of the tenets of our lifting agreement.
That's right.
To protect the pelvic floor.
And what we mean by the Prolapse Prevention Pact, which is binding, is that we are careful about managing our pressure system in our torso to be, I won't even say protect, because that feels like the pelvic floor is more vulnerable than it is. It's just to respect I love that. Respect the nature of how the pelvic floor, which is essentially a diaphragm, similar to the respiratory diaphragm, but inverted, how it works. And so we're going to start to lay some foundational bricks around what is the pelvic floor, what the heck I do.
Right. Well, you and I share so many patients, right? Over the years, we've like back and forth. We've also been each other's patients.
For sure.
Yeah. And it's all different things. Postpartum rehab, it's urinary incontinence over the lifespan, pelvic pain, constipation. I send them all to you.
Teenagers all the way through 90.
Right.
And women at all phases of their life can have various presentations of pelvic floor dysfunction. Most women throughout their life will experience some expression of pelvic floor dysfunction.
So pelvic PT for everybody. Also,
would be ideal.
What kind of patriarchal nonsense is it that it's so poorly covered so poorly covered and poorly reimbursed?
Right.
In terms of your
physical therapy in general is poorly reimbursed, but including
and especially
it used to be called Women's Health PT, which is not the section in the APTA is called Women's Health. And interesting, right?
I know that.
It's because not only women
only women have the pelvis. They have no other body parts.
No otother body parts.
They're just a pelvis.
Yeah. So it's now my favorite way to refer to it is pelvic health physical therapy.
Love that.
So, it also, one of the misconceptions is that it is solely related to the pelvic floor. The pelvic floor is a muscle group at the base of the pelvis. It comprises the bottom of the pelvic bowl and offers lots of functions, one of them being support to the pelvic organs, sphincter function for bowel and bladder, sexual function, very highly related with sexual function, and even spinal health, stability. Yeah. There's a lot of functions. I relate it with the deep
breathing,
highly responsive to breath. And, we'll get into a little bit more of the anatomy of that down the road, but, it's an incredibly important muscle group for bowel, bladder, and sexual function in women and men. But for the sake of this conversation, we'll kind of, focus on the female, meaning biologically F-origin female pelvis. Right. So, pelvic floor is very few people understand or even know or are aware of the anatomy of the pelvic floor.
Right. It's the muscle you use when you try to stop your pee.
And that can be a useful cue for some people.
But don't do that.
But don't do it while you're peeing. No. Oh, bless you. Did you use your pelvic floor? So, yes. And also, a lot of women first ever learn of the pelvic floor as the muscle to tighten the vagina to be a more amenable sexual partner, like a great partner because I'm so
Tighter.
tight. I don't love that.
No.
I don't love that because they completely miss the expansiveness of the muscle group. It spans from sit bone to sit bone. So the whole width of the pelvis, front to back, all the rim, the bottom rim of the pelvis. So it's quite expansive beyond just the vaginal squeeze or the stopping the flow of urine.
Mm-hmm.
So often when I get a patient, some from you, many from you, and they sit down and they will often say, I have no idea why I'm here.
But they're here.
Yeah.
I love that they still show up.
And I love when they start
Nicole told me I had to.
Yep. And I trust her. And I'm like, I trust her too. And some women are very, very nervous to come to pelvic floor PT.
Right. Yeah.
They're addressing.
It's vulnerable.
It's vulnerable. And they're addressing issues that have historically often been like, we don't talk about it.
Mm-hmm.
We don't address it. We are not comfortable even mentioning a vagina, like not talked about.
Right.
And so, over the years of my practice, I've gotten to really love the education piece of it because it's beyond just do your kegels, which, as you asked earlier, why do we name
all
that
the things
exercise
after old white men?
It's a German man. It's like a German. I think he's German.
An Aryan man.
In the fact check. Like
Mm-hmm.
Kegel says nothing about that. Like there's no, so if I teach them about the pelvic floor and then I say, these are your pelvic floor exercises.
Right. And there's not just one type. It's not just squeeze, let go.
No,
squeeze, let go.
No. And most women will do it that way.
Mm-hmm.
On, off,
all
on,
day.
Off, on, off.
The more the better.
More the better.
No.
Also not true.
Also very much not true.
Very much not true. So, anyway, when you send me a patient, the first day we do lots of education and learning and we look at anatomical pictures and we look at, diagrams and I have a 3D model of a pelvic floor that we, get familiar with why we're doing this. Like, what does this have to do with my bladder or my bowel? We think we have symptoms of bowel or bladder and, I have to go to the urologist or, the colorectal doctor or whatever. And that may be true for some patients, but often these symptoms are able to be addressed with some pelvic floor physical therapy. Pelvic health. So, and then there's a physical exam often, which is vaginal, usually, sometimes rectal, depending on the issue. And it's an assessment of what are the pelvic floor muscles doing? What's their understanding? What is their understanding of how to function? Are they strong? Are they able to relax? Are they coordinated? Do they have endurance? Not unlike how we treat any muscle in the body, right? If we consider a muscle healthy, it has all of those elements. It's not just strong.
Sure. We don't walk around with our biceps contracted all day.
Exactly. Mm-hmm.
Yeah,
exactly.
There's the contraction, the relaxation, and the release in between.
Exactly. And every muscle needs to be able to elongate as much as it shortens and contracts. And this may be most true for the pelvic floor because of the implications on bowel and bladder, sexual function. Major quality of life symptoms arise from some dysfunction in the pelvic floor. So without getting too in the weeds, and because we have been talking mostly about the perimenopausal, postmenopausal,
the
midlife. What some of the diagnoses that you send me, patients, when they're in your office, do you proactively ask them about their bowel or bladder function?
I do.
I love
that. You ask. I do that. Yes. I also ask them about how is your sex life?
Yeah,
that kind of thing.
Absolutely,
it's all related to the PF.
Do you ever notice how many people, women in particular, particularly midlife and on, have basically foregone sex? Like they're like, sort of,
and it's kind of like it is what it is.
Yeah,
like
commonly.
Yes, they do have that absence, but it's like it's like, and it is what it is. It's like bygones kind of thing. Like that part of my life is over. But then rarely I have this other patient who is like, sex life has never been better.
Mm-hmm.
Confidence is higher. She's treating the conditions of the vagina and the urethra that can happen with menopause, and therefore there's tissue integrity and sex life is improved.
She's lubricating appropriately.
Love that. And certainly, like, in a heteronormative couple, like the female pelvic floor is not the only thing involved in this declining sex life of age, but certainly
multifactorial.
That's mostly what we both cater to.
Yeah.
Is that side.
Absolutely. And it is one area where I find women often are saying to me, well, I'm getting older. So it's this messaging of like, I have to like let go or forego elements of my life that were exciting and fun and like not just sex, but like, physical activity often. And, because of these things that are inevitable and that I can do nothing about.
Well, the things that we're told by society, both consciously and subconsciously, like, do you leak urine when you cough or sneeze or jump for the the women who have children, who have had children? It's like, oh, well, yeah, I do that. But that's normal. I've had children.
I had the audacity to
common
have children.
Does not mean normal.
Good point.
Yeah.
That's a good theme to our work, I would say. And in this realm, it is incredibly common.
Mm-hmm.
And so when women are in circles with each other and, they're at their book club or, whatever, going for a walk and don't make me laugh, I'll pee my pants. And then everybody's laughing like, oh my God, me too.
Mm-hmm.
It's not necessary.
Mm-hmm.
It's not necessary. It's not normal. It's common.
And so in the menopause, postmenopause community, one of the biggest factors with declining pelvic function is the absence or the plummeting estrogen.
Right.
And the urethra, the bladder, the vagina, the vulva, all are very, very estrogenized tissues up until that point in life. And so when estrogen is low, there's a decline in function. So usually what I'm treating is with topical vaginal estrogen.
Critical.
But also sending them to PHPT with Lynn.
PHPT with Lynn. Or whoever is doing it. Please,
but
more of all the people do it. Yes, and that piece, since we have entered the realm where people are getting more comfortable with hormone replacement, the results of my practice have been enhanced because of it.
Yeah.
Because women that are like, absolutely, I'm not using any estrogen replacement. It's good. It's really hard to help them with their vulvar irritation, with their lack of urethral tone. I can't do much for that with musculoskeletally.
Right. I feel like the vaginal estrogen is a much lower bar for people to accept. It's not a systemic therapy. Yeah. There's not that blood clot.
It's a gateway in.
Exactly. There's not that theoretical cancer risk that comes with systemic. It acts at the source, and the benefits are very, very tangible and very like profound and rapid.
Yeah.
And when you stop, you can take it for your whole life until you die, like literally until you die. Yeah. And when you stop, you notice it.
Yeah.
It's very estrogenic tissue.
Right. For sure. And that integrity of the tissue becomes so friable post-menopause. So it's very
tender, sensitive.
Right.
Who wants to have sex?
And the reality is that their partners may be at that point using, erection enhancement, which prolongs erection. And if we're not addressing the female tissue health, that female
which no longer has an ability to lubricate, essentially.
Exactly. Then we're in a heteronormative situation. The male decline has been addressed pharmaceutically. Yeah. And then the woman is still receiving that.
Yep.
With tissues that are not like adequate.
Not sustainable.
Correct.
Yeah.
So, but back to the muscle, the actual muscle, of the pelvic floor, it's no different than any other skeletal muscle. With the decrease of estrogen comes sarcopenia, which is the atrophy or kind of like decreased muscle mass. So the pelvic floor is not immune to being affected by that. And so
weakness of the pelvic floor
becomes weak and it requires more consistent It requires that we address it more consistently as we move through life.
With strength training.
Exactly.
Oh, I'm sensing a theme.
Are you? It's your theme.
Yeah, it's true.
Ours. Your theme. Of course, in the clinic, we're looking at the pelvic floor. How is it functioning? And we're addressing that. And we're working, it's a lot of what we call neuromuscular reeducation to help the motor pattern develop. Most of the time, it's not redevelop, it's developed for the first time in a woman's life.
Wow, yeah. Right? Can you say that slower and again?
I will.
Okay.
So in the clinic, when we're addressing these motor patterns, with this particular muscle group, it is not as if a woman has ever had it before consciously. They don't think about it until there are symptoms that generate the need to.
Right. And it's an unconscious area of the body for the most part.
So for the first time, they may be becoming aware of this muscle group. And it's not a bicep that you can see, right? And, tangibly feel. It's kind of an elusive, more subtle sensation, that of contracting or, even relaxing, that of pelvic floor function.
And it kind of requires like quieting down the noise from everywhere else. You really have to be quiet and sit with it and just like focus in. So it can be almost like meditative a little bit.
It often,
especially when it's paired with the breath.
Exactly. And especially that's if we were up training or like, working on the strength of the pelvic floor. Absolutely true. And even more so if we are working on a pelvic floor that is holding too much tone and needing to down train or relax.
Right.
And you can't just say to that woman, relax your pelvic floor.
Just relax.
Relax.
Also, don't ever say that to any woman.
Oh my God.
About
so
anything.
Calm down.
Just relax. Calm down.
Opposite impact. But you can't, when I say we need to work on relaxing your pelvic floor, we need strategies for that. Because they feel like they are relaxing. And
just do it better. Relax more.
But that in particular requires physiological quieting and coming out of the stress response and finding general states of
nourishing the adrenals.
Relaxation, nourishing the adrenals, please. And the pelvic floor will follow suit.
Yeah.
And that pelvic floor isn't just because it's holding tone. That does not mean it's strong.
Right.
That means it's stuck in this middle place of like, I can't contract anymore, but I also can't relax.
And it's not a fun place to be.
That is
kind of a purgatory, really.
It really is. And so what I'm trying to do is help that person appreciate a greater amplitude of the function of the pelvic floor.
So what does a typical treatment plan look like? Like how many visits, how long do these visits take? And then what do people go home with in terms of a rehab plan?
Yeah. So good question. And it varies.
Sure.
But typically early on, I like seeing women frequently, twice a week. And it always is dependent on their schedule. Like sometimes you're sending me newly postpartum women. They're like, I'm sorry, you want me to come out of the house 2 times a week? It's not happening.
No.
So for that patient, I am doing a ton of education, support from afar, and helping them stay accountable, but with respect of their schedule. But generally, when I assess the pelvic floor, that helps me understand how long is this going to take for that woman? Because if they can't access it, they're like, I don't know how to contract my pelvis. I don't know what you're talking about. I don't know how to feel it.
Yeah.
But they're coming to see me fairly frequently early on, setting up a plan. It is not just exercises. It's also behavior patterns. Like if a woman is coming to me with urinary symptoms, often we have to do some bladder repatterning because
the just in case P's have got to go.
That's can we please stop? Just in case. PSA, stop. Let's do it. Make a PSA. Just in case. Oh, I'm going to pee. Just in case.
Just in case.
Oh, I have the opportunity here to go to the bathroom. I'm going to go. Just in case. It sets you up for the development of intense urgency and excessive frequency later. These are the people you might know, it might be one, where you're like, I'm going to go out, but I need to know where every bathroom in town is. And every time I arrive somewhere or I leave somewhere, I get the urge to go. It's not a real urge. It's just a trigger because we've conditioned the body, the brain and the bladder feedback loop to be overactive. Just in case peeing is like this. If I'm talking, I'm my bladder's saying,
Lynn!
My bladder's saying, I'm confused. And I'm saying, Me too.
Me too.
No. My bladder's saying, she went, but I didn't tell her to go. I must be dropping the ball. I'm going to send more urge and stronger urge to catch up with what she's doing. And so I've overridden the system. The system then responds to me.
Right.
Also, the bladder forgets how to fill all the way because we're usually, with just in case, we're emptying too frequently before the need arises. And so
the bladder then compensates by giving the urge sooner because it's used to that.
Right. It's a quarter half full and it's like, oh, this is when I send urge. And it's often not that kind of urge where it ramps up gradually. Right. And you're like, oh, I should probably think about getting the
all of a sudden I have to go.
All of a sudden I have to go and it's emergency. My car's on fire.
Yeah.
Not fun.
No.
Not fun.
Hard to go anywhere.
It is incredibly, I cannot overstate how urgency and frequency, definitely when that's combined with leaking of any sort, the quality of a woman's life goes down dramatically. Dramatically.
Yeah.
And so.
And it's such a silent thing. Like, it's not anything that feels like sexy to talk about or like,
no woman feels sexy when they're leaking urine into a pad.
And they're not going to bring it up with their provider typically unless they're specifically asked about it.
For a couple of reasons. They're embarrassed, ashamed, don't want to talk about it.
Or it's normal.
They think it's normal. That's the one that's like, that's why I asked you, and I appreciate that you are a provider who asks women this. Because they may think, oh yeah, but only when I sneeze. That's, time to intervene. Time to intervene. That's enough. Because it will just progressively and very slowly get worse and worse, and a woman will accommodate. Oh, I guess I should progress to the poise pad. That industry loves this, right?
And then all of a sudden they need a surgery.
Right.
Like to that point where, they're can't engage those muscles at all.
Right. Right. Or, the surgeries will happen when the bladder is also dropped. And that can be concurrently happening as we move through life because the connective tissue and the musculature is losing integrity as we age and lose estrogen.
Oh, estrogen.
Oh, it's estrogen. I keep coming up with these.
We need to start like a bumper sticker line.
Okay.
Estrogen line.
Adjunct business venture.
Yeah.
Get on that. So yeah, urinary incontinence, urinary habits. So in the treatment, I'm talking about all of that, like guiding women through that as well. It's so funny that physical therapy, because a lot of women will come and be like, I've been here for my knee, but this is a totally different process.
And this is, when there's a physical exam related to this area of the body, like it's not in the room with all the people. It's like in a private exam room.
Yes.
Yeah.
It's in a private exam room, quiet. It's, and, it's very well explained why this has to happen. And it doesn't have to happen. Like
you can guess by symptoms what's going on. Yeah. And you've done in the past as well, you've done a fair amount of telehealth therapy, right? Especially for the postpartum moms.
During COVID, absolutely.
During COVID.
Postpartum, yep.
It's nice to at least get like an initial in-person baseline, but then you can do a lot of consults, just by video.
100%. The physical exam is ideal.
Yeah.
Absolutely ideal to get that super accurate,
individualized.
Yeah. The number of women who are bearing down like they're going to poop or have a baby when they think that's what they're supposed to do to draw the pelvic floor up and in is really interesting.
Wow, yeah.
So it's like a reversal of the pattern.
Right.
And so that's very difficult to catch without doing an exam. Ideal to do an exam. But this is what our whole purpose here is. There is so much that can be done through education as well. One of the motivations I have with our platform here is that, we're educating people because it is getting harder and harder and harder to access practitioners for everyone. And so if there is education that can help move you in the right direction, why are we withholding it from women?
Yeah.
You can't answer that?
No, I can't answer that.
There is no answer. So
no longer.
But in the visit, when you send me, we keep tangent
hone it in,
but
tighten it up.
Just bring it up. You asked about what kind of treatment plans are there. Education around, depending on symptoms, bladder patterning. Often with the patients that are having pain with intercourse, there's relational dynamic conversations that come up. Sometimes there's trauma conversations that come up. And within my scope, I'm adjusting those because they're a huge portion of helping a woman move through. I have referrals to psychotherapists and people who can help, move a woman through this process beyond just the physical realm.
Shockingly, it's not existing in a vacuum.
It is not existing in a vacuum.
Yeah.
Yes. We can be reductionist about all of this.
Right.
We can't.
Right.
I mean, it's a big Venn diagram.
Yeah.
And I'm talking about hydration. I'm talking about nutrition, especially if there's constipation involved. And it's fun because it ends up being sort of like overall health coaching and the like true physical therapy is the assessment of the musculoskeletal system, including the pelvic floor, and then the application of exercises or a plan. The exercises typically, and this is gonna really land for reverence, we do isolated pelvic floor work, as like we were talking about, to create that neuromuscular pattern to help a woman feel more connected with this part of her body. A lot of women are cut right off in this part of the body because it's like the enemy. If it's weak, if it's painful, if they've, had C-section and things are different, if there's prolapse,
well, our attention only brought to it when there's something off. Something's not functioning well.
Right. So we're doing some, specific isolated pelvic floor work, depending on what the woman needs. Also, and more far-reaching, in my opinion, are the lumbopelvic stabilization and strengthening programs that I create for women. And it's resistance training. It is strength training. The research is really strong. Even if you do nothing for the pelvic floor, strengthening the hip rotators and the glute medius, that's an abductor of the hip, really just the whole pelvic girdle, that will improve urinary
function,
leakage, urgency, frequency. Those symptoms will be improved through, even if you do nothing else, strengthening those muscles of the hips.
Right. And that's where the in-person piece is important as well, making sure you're doing that movement with good form and good integrity and not just kind of muscling through it. Or could you make it worse with some of these movements if you're not doing them well?
I think that if you're not moving well, you can make most everything, maybe a little worse. But more importantly, I think in physical therapy, there's this like culture sometimes of, I'm the one who can tell you how to move well. And so what ends up happening is then the patient is scared to move on their own. And we don't want that, right? So there's a broad window of moving well. It's not a like thin needle to thread.
Right.
And so I want to convey that because getting moving, whether it looks like perfection or not, is the most important thing. Moving your body. The pelvic floor will decline. Symptoms will arise, just like every other system in the body, when you're sedentary.
Right.
And so, as we design our plan, our signature plan to help women, usher women into strength training, it is, the exercises we are selecting are for a reason.
Right.
And also, if they don't look like exactly how they're supposed to, it's okay. You're doing it. You're moving. If you're squatting and you're moving, if you're moving vertically through space and you never have before, you're doing a better thing than you were before.
For sure.
Will we help you fine tune that movement? 100%. Yeah. But you don't have to go to somebody in person to start and to make good impact in your life. Is it ideal? 100%. We live in the reality of a healthcare system where that's not, you can't come forever accessible to somebody like that. And sometimes some people can't come at all.
Right.
And so move either way. Ideal, of course, is to have somebody with you, coach or some trainer, somebody with some knowledge. Awesome. It's awesome. Not realistic.
Not realistic. Right.
Yeah. So my treatment plans involve a more global strength training approach. And that is because the healthier muscles around the pelvic floor are, the healthier the pelvic floor will be. It is not unlike the deep abdominal core muscles in that way. It should be reflexive and it should respond to forces placed on the body around it.
Right.
And if we don't wake it up, then it won't.
We just all need to wake up.
I want to go to bed.
Okay. Good night.
Yeah, we'll talk more about this in the future, but I do want to acknowledge that when you send me a patient who's having pain with penetration, that pelvic floor probably has different needs than somebody who might be, experiencing urinary incontinence.
Yeah.
Whatever. And postmenopausal, often that pain with depth gets relegated to that you need to lubricate and that you need estrogen. Those are both true. The one other piece to that puzzle is that if a woman is holding tone in her pelvic floor
and has been her whole life,
maybe has had one painful sexual experience, that can mean that the body, the nervous system, protectively goes, no thanks. It closes the aperture. And so the musculature gets quite tight.
Sure.
And so that is a different process. We will get more into that. That can involve some different myofascial release techniques. I just wanted to acknowledge it during this intro discussion.
Not a comprehensive.
This is not comprehensive.
Yeah.
But hopefully it allows people to start to think about some of these things and to understand what pelvic health therapy is.
Yeah. Sorcery.
Nicole, after the first patient Nicole and I ever shared, she sent me a text message. The patient went back and was feeling great. And I got this text message that said, "You're a sorceress."
Yeah.
With the little wizard emoji.
Oh, yeah.
I felt so
Love that
proud.
emoji.
I really felt powerful when you sent me that.
Yeah.
It was great.
Grateful for you.
Thanks
Appreciate
for all the
you.
collaboration.
Yeah.
Back at you.
Till next time.